So I'm really delighted to introduce Dr. Karen Smith, our California Public Health Officer and Director of Public Health. She has just come into this job with so much energy and passion, has a work group where every single branch of government affected by the epidemic is coming together monthly to work on it, set up task forces. This woman does not rest. So please come up and tell us a little bit about your work at the state level and what we're seeing in the data and what's next. Thank you.
Yeah, so as usual, public health has to come up and bore everybody with data. The stories you just heard really are why I'm so passionate about this work, this public health problem as I see it. Let's see if I can make this thing work. I am going to religiously, okay. Is it going? I can't see it. Okay. Well, that's interesting because I'm looking at something entirely different. All right. I'll just assume it goes when I said it goes. He's waving at me. Yep, 10 minutes. I got it. We'll talk fast. At any rate, I'm delighted to be here. I was really fortunate to be able to come last year to the kickoff of this event and to see this many people here really committed to working on it. And a shout out to my public health colleagues. Awesome that you're here, but I have to say, the most exciting thing is seeing clinicians take time out of their incredibly busy schedules and actually carve it out to come here and learn from this interdisciplinary group of people is inspiring. Those of you who aren't clinicians don't realize how hard that is to do, which isn't to diminish anybody else's efforts. It's just, it speaks to the fact that the healthcare realm has really sort of owned up to the fact that we really have to change what we do in medicine along with all of the other things that we'll be doing with our partners. So it's very exciting to see everybody here. I am going to just highlight a few things that are going on at the state level. First, I want to say that to me, this really is an epidemic. And the first time I asked for money for this, it came back from the administration saying, could you use a word other than epidemic? And I said, no. Because it is an epidemic. I mean, it's the literal definition of an epidemic. And like any other epidemic, it requires a multidisciplinary approach. It requires interventions at every single level. I'll talk a little bit about what we're doing, but I want to first give you just the tiniest bit of data because that's required for our jobs. I'm just going to skip past this. Whoops. Oh, see, this is moving on a different presentation. That's disorienting. Okay, so I'm going to whet your appetites for data, but I don't have to give you a lot because there's going to be a fabulous presentation at lunch, which I think you should all see our new data dashboard. You're going to have the opportunity to beta test it. It's pretty much, I think, ready for prime time, but we want to be sure that it's providing you the use. But bottom line here, this is some of California's emergency department data and opioid prescribing data. The blue line at the top is the opioid-related emergency department visits, and the red line on the bottom are the opiate prescriptions dispensed in California. So there's some very good news here. After years of steep increases in the opioid-related ED visits, the line, while still increasing, has slowed. The rate of increase has slowed, and that is a huge thing when you consider how fast this was moving. We've managed to slow the train down a little bit. The rate at which opioid prescriptions are being issued is flat. That's obviously better than increasing, but it's not what we want. We want to see it really decreasing overall across the state. And again, this is state level data, realizing that in every community the data is going to be a little bit different. So now here we have the heroin use. This is a huge, and it's going to become an even bigger problem. So we can't just look at prescription opioid abuse because the heroin epidemic that's really picking up speed is a direct result of what we've done with opioids, and the people that we have managed to have become dependent on opioids, when we take those away or when they're not working anymore and they're not getting the solutions they need to live their life, they're going to turn to what else is available, whether that's fentanyl or heroin or any other potentially incredibly dangerous drugs. These are much more powerful medications than the opioids, and they are killing people every single day. So as this epidemic expands beyond the healthcare system, we have to expand our interventions in the same way. There is not a community in California. Not that I've looked at every single one of them, but I will wager any sum of money or whatever I don't have a kid, but my dog, that every single community in California is affected by this epidemic. But they're not equally affected. We do have areas of the state that have a much higher burden. If we look at the northern counties, the mostly rural northern counties, while the overall numbers of individuals are small, the rates are really high. And that's one of the reasons that a lot of the work that we're doing at the state level is focusing there first. If we can target the limited resources we have using data to drive many of the decisions, we can get a bigger bang for our buck. So I hope that's whetted your interest a little bit for data. I'm not going to suffer you through any more, but I do want to just give you a sneak peek for why you should listen at lunch. This is a static view of the state level dashboard that we're going to be providing to you today. It includes data from 4 sources. We've got the deaths data, ED visits, hospitalizations, and the cures prescription data. Multiple indicators of progress or lack thereof in each of those areas, both at the state level, but even more excitingly for you, at the county level. So you will be able to interactively on this dashboard dive down to see how you're doing in as close to real time as the data currently allows. And so I think you're going to find that really exciting. And you're going to be the folks who get to use it first. And we're hoping you will give us feedback on how we can continuously make it better for you. So at the state, I want you to just remind you the things that we are working on. The focus for us are 5-fold. Our work group, which has expanded significantly beyond state agencies and now includes the California Healthcare Foundation. They were the first outside partner to join us. The DEA actually came to us and said, can we please work with you, recognizing that this isn't an issue that they can just use the traditional approach. We give them huge kudos for that, and they have been an excellent partner, but lots of community organizations as well, and so we're very excited about that. We're continuing to focus on safe prescribing, access to treatment, naloxone distribution, public education. This is a big part of what we're trying to do, is really reach out to the general public and engage them in this conversation and get them to commit as well to making changes in our communities. And then finally, using data to inform the strategies and the places, the direction that we use for those strategies. We did receive a grant from the Centers for Disease Control and Prevention last year to support this work, and it has just rocketed. And I don't have time to thank all the members of the team, but I really appreciate your work, and I know that it's making a direct impact in communities. In addition to that, we have had so many partners wanting to work with us that we have expanded, as Kelly mentioned, to new task forces. So we have 4 task forces. They're working on communication and outreach, data gathering and sharing, integrated healthcare policy, and treatment. These 4 are working actively, and they're seeking to expand their membership. So if you're interested in one of these areas and you're looking for something else to do, like the obviously irrepressible pastor here, let us know. We'll get you involved. They're at different phases, but each of them right now is working on concrete action plans to advance the area that they're looking into. And we're helping to support that work. We also have a grant in to support a public education campaign, a really large statewide public education campaign that we're going to want to work with you on to make sure that we allow for tailoring in the areas where you're already working. We want it to not look dissonant. I know some of you, our ex-Marine, for example, has a really strong public outreach. We want to help with that, not get in the way. We want to be synergistic. I'm going to leave you with this. The most important thing is that we really look forward to supporting your statewide, and in the case of some of our partners, but also your local interventions, your prevention. Even though the coalitions are really only involving, is it 21 or 22 counties and regions, it's really important that you know that everybody else is watching. They really are learning. It's amazing how well the best practices, the things that you're finding work in your areas, are leaking out into surrounding areas. And we really want to facilitate that and make sure that everybody hears about the things that work, because your community may have similarities to another community. Something that's working there may work well in that community as well. And the interventions that you're putting in place, and in particular, I'm very happy at the refocusing on the availability of treatment and medication-assisted treatment. I was medical director of the Alcohol and Substance Use Division when I was the health officer in Napa County. And we were struggling with a cultural issue within the counselors. They came from the world that said, you know, no medication, no drug at all. Fortunately, we now know that actually, there are biological reasons why that works for some people, but it doesn't work for the majority of people. And so bringing medication-assisted treatment is going to be huge. But the only thing that's going to be sustainable is if we activate our communities, if we get the communities, the people in the communities themselves involved and engaged in positive interventions to address this, we will be able to sustain it. And we will be able to put opioids where they need to be and keep them from causing unnecessary harm. So that's it for me. Thank you very much for the opportunity to speak to you. I look forward to sharing the day.